So I want to start by thanking MQ and the Wolfson Foundation for making that research possible. So let's see if that works. Great. So it's quite well established that adults are at an increased risk of a range of neurological and psychiatric outcomes, but in particular cognitive deficits in the 6 months after a COVID-19 infection. But there's quite a few known unknowns, and one of them is what happens after 6 months. One of them is, are children as affected as adults are? Has Omicron changed things, and what can we do about it? We try to answer these questions using electronic health record data from Trinetics, which is an electronic health record data network in the USA, which comprises data from about 89 million people, both insured and uninsured. And out of them, we managed to identify 1.25 million patients with COVID-19. And then we created a matched cohort of patients who had another respiratory tract infection during the pandemic. And that was very important, so that they were affected by the pandemic in the same way as patients with COVID, but they didn't have COVID. And we compared the risk of 14 neurological and psychiatric disorders in a 2-year after infection. And we stratified the analysis between children, adults, and older adults. And then we looked at the effect of different variants. I'm going to focus on Omicron today, but the effect of variants by looking at people diagnosed with COVID-19 just before and just after the emergence of the variant. So in a more graphical way, this is what we did. We did a very standard retrospective cohort study with matched cohorts, and we controlled for as many confounding variables as we could think of that were available as part of the electronic health record data. And these are the outcomes that we looked at. So we looked at a range of outcomes that capture both sort of more psychiatric and more neurological outcomes. And the ones that are of particular interest for this study are cognitive deficits and dementia. I should say that out of all the outcomes, cognitive deficit is the one that's the odd one out, in the sense that this is not a strict ICD-10 diagnosis. So we try to be quite pragmatic and capture that concept using ICD-10 codes that would sort of represent brain fog, and that we think clinicians might have used to represent brain fog. So the first thing that we did is looking at risk trajectories, and here's what we found. So we can represent a risk trajectory using Kaplan-Meier curves. Now, this is a bit of a mouthful, but it's really a simple concept. For those of you who are not familiar with it, this is simply looking at the cumulative incidence of the outcome over the 2-year follow-up. And that sort of represents and encapsulates the entire risk trajectory when we compare the COVID-19 group in pink with the group suffering with another respiratory infection in blue. Now, there's quite a few information we can extract from those risk trajectory, and one of them is what we've called the risk horizon. And that is the question of at what point is the risk between the cohorts the same? At what point does it become the same? And I think that's an important question for patients, because I had COVID over the summer for the first time, and I've been lucky enough not to develop depression, for instance, so far. And I'm interested to know, am I still at a higher risk of having depression compared to if I had had another respiratory infection? This is also important for clinicians. You see a patient and they have a new psychotic disorder, and you're not quite sure why that is. And you notice that they have had COVID 6 months ago. And you might want to know, well, is it possible that COVID is still contributing to psychotic disorders 6 months later? And obviously, it's also very important for public health policymakers, because we want to know to what extent services need to be reinforced to be able to face the increased demand for making diagnosis and treating those disorders. Now, you can try to work out the risk horizon from those curves, but the best way to do it is to look at the hazard ratio over time. So this is a time-varying hazard ratio, and for the most sort of mathematically minded in the audience, this is essentially the ratio of the first derivative of the Kaplan-Meier curves in a nutshell. Now, when you look at the hazard ratio over time, the risk horizon is by definition the time at which the hazard ratio reaches 1, which for cognitive deficit, as you see on the screen, is never reached in the first 2 years. And this is unlike things like neuromuscular diseases, for instance, where you see a risk horizon occurring at about 500 days. So whereas for neuromuscular diseases, after 500 days, you can be confident that your risk of being diagnosed with this disorder is the same as if you had been diagnosed with another respiratory infection rather than COVID. This is not the case for brain fog. You can then map those risk horizons for all the outcomes and try to see whether you can identify some patterns. And there are some patterns indeed, and some good news. The good news are all on the left. So this is outcomes for which the risk horizon is actually quite short. It actually occurs quite quickly. And this is the case for mood disorders, anxiety disorders, ischemic stroke, and insomnia. Now, perhaps it's not too surprising for ischemic stroke. You don't expect, so ischemic stroke is basically blood clot in the brain. So you don't expect that a year and a half after having had COVID, you're still at an increased risk of having a blood clot in your brain for the first time. But this is very good news for mood disorders and anxiety disorders, and definitely not something we expected. After about 43 days for mood disorders and 58 days for anxiety disorders, your risk of having those outcomes after COVID-19 is the same as if you have had another respiratory infection rather than COVID. That's great news. But there's also some bad news, and the bad news are all on the right, and those are the outcomes for which there was no risk horizon that was reached. That means that 2 years after COVID-19, people were still at an increased risk of developing or being diagnosed, at least, with those disorders compared to if they had had another respiratory infection. That includes cognitive deficits, as I've already shown you. That also includes dementia, perhaps unsurprisingly. That also includes psychotic disorders and epilepsy and seizures. And so those outcomes, I think, deserve quite a lot of research attention. This is another way of looking at it. So you can see the Kaplan-Meier curves for those 4 outcomes at the top and the risk horizon at the bottom. And you see that the risk horizon never quite reached that line of no difference. Now, another thing that you can be interested in is what happens after the risk horizon. Do the curves continue to sort of diverge, as is the case for cognitive deficits, where they never reach, indeed they never reach a risk horizon? Or is it the case that they sort of at some point join? Now that's a different thing compared to the risk horizon. What that means is that at that point, at the time of equal incidence, the total number of people who have had that outcome after COVID-19 is the same as the total number of people who have had it after another respiratory infection. The fact that this is the case for mood disorders and indeed for anxiety disorders means that not only is there a point quite early on, as we've seen, where your risk of developing those disorders is the same as if you had had another respiratory infection, what it also means is that if you had had another respiratory infection, your risk then becomes higher than if you had had COVID, so that after 2 years, the total risk, the total incidence is about the same between the 2 cohorts. So just to summarize the risk trajectories, one thing that I haven't shown, but which is part of the paper, which by the way is open access, and so you can all read it, is that we've confirmed earlier findings that if you only look at the first 6 months, you do see an increased risk of a range of neurological and psychiatric disorders. However, we see that the increased risk sort of comes back to a baseline, which is the risk that you expect after any other respiratory infection for mood and anxiety disorders. The bad news, however, is that for other disorders, including brain fog, dementia, psychotic disorders, and epilepsy and seizure, the risk continues to be elevated after COVID 2 years after the infection. Now, what about children? We did the exact same analysis in all 3 age groups, and that includes children. And so I can directly jump to the conclusion. Again, there's some good news and some less good news. The good news, and of particular interest when we think about brain fog, is that the risk of brain fog, so cognitive deficit in children, is transient. What that means is we do not see an increased risk extending all the way to 2 years after the infection. But more importantly, we also don't see an increased risk, an increased overall incidence after 2 years compared to children affected with another respiratory infection. And that's very good news. There was some more worrying news. One of them is that children are at 2-fold increased risk of epilepsy and seizure after COVID-19 compared to other respiratory infection. And children are at a 3-fold increased risk of psychotic disorders after COVID-19 compared to other respiratory infection. However, the absolute risk there is absolutely minute. So bad news, but not as bad as if the overall risk was higher. This is just the curve. I love to see that. Look at that curve because I think this is hugely reassuring for children. You see a spike of cognitive deficits early on after COVID-19, but then that quickly goes back to a risk horizon after a couple of months. And then you see a sort of downward trajectory, which indicates that there is a catching up that operates in the control cohort. And this is very reassuring. And the spike, by the way, is probably accounted for by delirium rather than actual brain fog. And that's because delirium was one of the sort of pragmatic ICD-10 code that we used to try and encapsulate as many ICD-10 codes as we could to represent brain fog using ICD-10 codes. Now, what about Omicron? We took advantage of the fact that Omicron in particular, but actually most variants, had a very quick onset. So as soon as Omicron hit, it became the sort of dominant variant very, very quickly. And what that means is you can compare people diagnosed with COVID-19 just after that variant became dominant compared to just before. Now, it doesn't mean that there's no contextual factors that might still be contaminating the findings, but at least they are reduced to a minimum. And because we have access to quite a large data set, we can still keep a lot of statistical power while keeping those time windows very narrow. So what you can see is that we compare people diagnosed in a period of 2 weeks after the emergence of Omicron compared to people diagnosed sort of in the 2 to 3 weeks just before that. We looked at all outcomes that I've discussed, but I'm just showing here the results for cognitive deficits, dementia, and any first. What you can see is the risk if you just look at those outcomes, and that's the sort of squared lines. So this is just the risk of those outcomes occurring in the population. And then you can look at the composite risk of that, so cognitive deficits or dementia, composed with death. And you see something quite interesting. What you do see is that the risk of the outcome itself is the same after Omicron, or indeed a bit higher for dementia after Omicron compared to just before Omicron. But if you take into account death as a composite endpoint, then you see that the risk is much lower. What that means is, as expected, and we replicate the good news that has been shown by many other researchers before us, which is that Omicron is a milder illness, and that's a very good news. So you're less likely to die from Omicron. However, if you're surviving Omicron, your risk of having sort of cognitive deficits or dementia is approximately the same as it was before. Another way of looking at it is to look at it in a sort of graphical way, and don't look at absolute numbers here. This is purely for illustration. It might be the case that the total number of affected people and unaffected people both go up. And the reason why that is because the number of people who die decreases. So if you are a patient, you're probably interested to know whether you are going to be affected or dying from the illness. In other words, you're interested to know whether you are going to be unaffected by COVID along that outcome. And what you see is that with Omicron, that number goes up. So you're less likely to have either the outcome or to die from the disease. If you are a health service provider, you're certainly also interested in people who die, but you're also interested in knowing how many people will go on to develop the disorder, because that indicates how many resources you need to put in to diagnose and treat and manage those disorders. And that number also goes up after Omicron. So for public health, this is not a great news. For patients, this is better news. So in summary, Omicron leads to milder acute illness and fewer deaths. However, it leads to similar risk of neuropsychiatric sequelae, including brain fog and dementia, compared to Delta. There are some important limitations about those studies, and I'm sure many of you will be aware of because I've seen many people working on electronic health record data. But there are some specific limitations regarding COVID. One of them is that it doesn't represent the entire population of people diagnosed with COVID. As I said, I had COVID over the summer. I didn't seek medical attention for it. I didn't see my GP for it. My GP does not know that I had COVID. It's not in my electronic health record. Those findings might not apply to me and to the many others like me who did not seek medical attention for it. Vaccination status that we took into account in our study as a covariate was slightly underreported, and that's probably because people were vaccinated in vaccination centers, as it's the case in the UK. And so that might not feature in the electronic health records. Variance data was based on dominant variants at the time, not genotyping. We did not go and genotype 1,250,000 people. We don't know when the disorder began, how severe it was, and whether it got better. And an important one to keep in mind is that all those risks are relative to people with other respiratory infection. So when I say that the risk goes back to baseline, this is very much baseline that we expect to see after another respiratory infection. This does not mean that this is the baseline we necessarily expect in the general population. And then finally, we don't know the how and the why of those findings. Now, what can we do about it? Well, fortunately, there's a lot of people working in trying to understand why it is that people develop brain disorders after COVID. And one of the nicest studies I've seen so far is this paper in Nature Neuroscience, where they've shown that COVID-19 is associated with an increased damage to small blood vessels. This is based on small animal studies. And they've shown that in mice treated with a RIPK inhibitor, this damage sort of was less severe or indeed absent. No, I didn't know anything about RIPK inhibitor, but a quick look at the literature indicates that there are some RIPK inhibitor used in clinical practice routinely. One of them is phenytoin. Phenytoin is not used as a RIPK inhibitor, but among its many effects, it's got RIPK inhibition. And so we thought that we could test using electronic health records data whether patients with epilepsy exposed to phenytoin at the time of COVID-19 were at a lower risk of developing brain fog compared to people exposed to another anti-epileptic. Now, I should say, because I'm not an expert in epilepsy, and I don't expect that all of you would be, that phenytoin itself is actually associated with cognitive deficit. So in a way, we're sort of shooting ourselves in the foot by having a bias against what we were hoping to identify or to confirm. And what we found is that compared to two very commonly used anti-epileptic drugs, again, sort of matching for all other confounding factors, phenytoin was indeed associated with a 22 to 27% decreased risk of brain fog at 6 months after COVID-19 infection. So that might sort of provide some support for the hypothesis that was nicely laid out in the Nature Neuroscience paper. Another thing that we can do and that we are working hard on right now is, and that's very much the gist of the CFOG study that we are running, is to try to see whether we can predict who is going to develop brain fog after COVID. This is both because it might give us a hint as to what the mechanism might be, but also because predicting who is most at risk might help us in designing intervention, identifying people suitable for interventions, and recruiting patients in randomized clinical trials to test those interventions. And so that's where we are heading. And with that, I'd like to thank you very much.